Okay, I know that was a little bit of a short break, but we're very excited to continue our critical care focus program. And very relevant to the issue of sepsis is Dr. Alyssa Letourneau, who's here to talk to us about empiric antibiotics in the ICU. Thank you so much for joining us, Dr. Letourneau.
Thanks for having me. And I think you all have access to my slides. I made many more slides than I probably have time to go through, but there'll be some rapid fire items and a lot of things just to have for your reference for later. So I do write some of the cards for up to date on antibiotics. So that is a disclosure. And then we are running a simultaneous course for the infectious diseases, and I do a couple talks on antibiotics. So I have stolen some of the slides that I used for that and have given credit to my colleagues who helped put those talks together. So really, I want to talk a little bit about antimicrobial stewardship since I run our program here, sort of making sure we keep in mind the balance between making sure we treat our patients appropriately for sepsis, but also be very thoughtful about the antibiotics that we're selecting. Help you sort of think about how you select antimicrobial therapy or antibiotics, which many of us do this without really thinking twice. But I think it's helpful to just go through the steps of the things that we're actually doing when we select those antibiotics. Although I know like vancomycin, vancomycin sort of is the knee-jerk reaction for patients coming in, which for the most part is appropriate for most of the patients in the ICU that you are seeing. Think about what are the real risk factors for multi-drug resistant organisms and when we really need to be thinking about that and when maybe ceftriaxone would be appropriate. And then review some of the updates on extended spectrum beta-lactamase producing organisms, AMP-C producers, and Pseudomonas aeruginosa that's drug resistant, which for some reason our society has decided to call difficult to treat Pseudomonas aeruginosa instead of MDRO or multi-drug resistant Pseudomonas aeruginosa, but I've tried to keep that language consistent since that's what the guidelines use. So, I feel as though antimicrobial stewardship, teams have sort of had the sort of police hat entity for many years, but I would say, and I would hope my colleagues who are running this course don't see us sort of that way anymore, and that really we're trying to promote the best use of our antibiotics that is important for our patients so they have the best outcomes and that's safe for the patients as well, so that we can in the end decrease sort of the spread of these drug resistant organisms. And I know there are some hospitals actually in our system, I think, where there's a little bit more police sort of aspect, but really my team is here to help make sure that the patients are getting what they need. I am not one, I trust my ICU physicians and typically will approve, if they're calling for a carbapenem or some other antibiotic, I typically say yes, because they have the patient in front of them sort of in seeing that, unless there's clear data pointing to the fact that they don't need to give this. So I'm definitely going to date myself, although for the older people in the crowd, although we are older, how do you decide which antibiotic you're going to give? And as I mentioned, sort of the knee-jerk reaction is vancomycin, so some sort of gram-positive agent. I would say vanco is probably still the workhorse in most hospitals. It's still pretty cheap. It is one of the most used antibiotics in our system here. And then cefepime or piptazo, so some sort of beta-lactam that has anti-pseudomonal coverage for patients. And so how do I think of selecting antibiotics? And really, as I said, all of us do this pretty quickly when patients are coming in, but, thinking about if you step back and sort of think like, what is the syndrome that they're coming in? Who is the host? Are they immunocompromised or not? What pathogens must I not miss? Because if I miss it, they may die. So your Staph aureus and your gram negatives, what sorts of allergies do they have? What other problems do they have as in devices in place, valves, Foleys, et cetera? And really, what are your resistance patterns? So the microbial resistance here in Boston is very different than what it is in New York and sort of the empiric regimen, New York City. So the empiric regimens differ in those two areas because of what we see in terms of infections. And then where is the infection? Because your antibiotics have different penetration into different areas of the body. And then once you have a microbiologic diagnosis, first of all, does it fit sort of the clinical syndrome? So it's not unusual that maybe you get a coagulase negative Staph aureus in the blood, which is typically a skin contaminant. If it's in one blood culture out of 4, is that really what caused the patient to come in with sepsis? Probably not. And therefore you can sort of think about taking away some antibiotics based on that. Does the bacteria need to be treated? Similarly, sort of an enterococcus in the urine is typically not a problem depending on what the patient is coming in with. and what's the best antibiotics? So what drug should I be using for the bug that I'm finding based on any evidence, which we don't have a ton of, but we have some. And then what's the shortest duration we can give? Hopefully most of your patients are getting out of the ICU and you don't necessarily have to decide on that duration, but shorter is better. Which I don't think I get into this talk, but there are more and more data, and I know our ICUs have been good about this, for VAP, for ventilator-associated pneumonia, for example, that 7 days of antibiotics or 8 days if you're across the sea is sufficient for ventilator-associated pneumonia, and that has been compared to 14 days, which is great. As you all know, the most common pathogens causing sepsis are your gram-negatives. E. coli, Klebsiella are sort of the most common, and then the gram-positive Staph aureus and strep pneumo. And actually, I probably should have added group A strep here because there has been sort of an uptick in group A strep sepsis and bacteremia. We've seen several cases here that have actually resulted in death, and that is something to keep in mind in some of our patients in this day and age. And then once you've started your antibiotics, if patients aren't improving, what are other things that we need to think about? Could they have some other viral infection or fungal infection that's not bacterial where my antibiotics aren't working? Is there some non-infectious process that's mimicking infection? Is there some local or systemic host defense system that's not working? So if somebody has a big swollen arm with lymphedema, is the lymphedema the problem and not necessarily the antibiotic? And then all the other things, additional infections, adverse drug reaction, do they actually have drug resistance? Am I dosing my antimicrobials appropriately? So, in the ICU, we see patients who are getting renal replacement therapy, maybe they're on ECMO. These things affect the clearance of our antibiotics and sort of making sure, working with your pharmacist to be sure that those are dosed appropriately. And then is it the right antibiotic for the site of infection? This is what I mentioned before. For drug-resistant bacteria, for example, something like tigecycline doesn't get into the bloodstream, so you never really want to be using that for a bacteremia, but it is excellent for skin and soft tissue infections, abdominal infections, sort of anywhere else other than the bloodstream. And then is there a problem with source control? Is somebody fevering and not responding to antibiotics because there's a big abscess in their belly that has not been drained? I always like to say pus under pressure is always something we need to be looking for if they're fevering and we think the antibiotics are correct. Do they have an obstruction somewhere? Is there a foreign body that we need to take care of? All right, so those are our basics, which most of you know. Now switching gears and addressing sort of once you have some susceptibilities or maybe patients are colonized with these, sort of how we think about it. So MDROs, or multi-drug resistant organism factors, really, I think like the standard, and these were all updated, I guess not recently anymore, about 9 years ago. When do we really need to be thinking about Pseudomonas and Staph aureus, or methicillin-resistant Staph aureus, MRSA, in patients coming into the hospital? So patients who have been in the hospital for a long time, which most of us know this, and recent exposure to antibiotics is really the two things. And obviously, if they're colonized and they're flagged, which most of us have electronic health records, and people will get flagged and have some sort of potentially have precautions listed for them. And so, again, I'm not going to go through each of these, but essentially for ventilator-associated pneumonia, as I mentioned, patients who are sick and have been sick before they get their VAP, and people who have seen IV antibiotics in the last 90 days. This is sort of standard. I don't think anyone that's in the audience would start ceftriaxone on somebody who has a VAP who's been in the hospital, because that would not treat your Pseudomonas aeruginosa. But these were all outlined in the paper guidance put out by ATS and IDSA 9 years ago. And this was a big switch from what it was before. And then patients with risk factors for MRSA include those who have a high rate in their hospital systems, or if they actually don't know, or if the patient has been colonized with MRSA. And I would say, one of the nice things is there are great data showing that if you do a nasal swab for MRSA, and their nasal swab is negative, you can pretty much safely remove stop the vancomycin in those patients, because the likelihood that they have MRSA pneumonia is extremely low. It is not zero, but it's almost zero. I would say a patient with necrotizing pneumonia, that might be the only place that I would hesitate for doing that. But the standard patient coming in with pneumonia, if they have a negative nasal swab, whether it be culture or PCR, can safely be de-escalated. And these are for HAP, so non-ventilator hospital-acquired pneumonias. Similarly, basically IV antibiotics in the last 90 days. So that's the thing I tried to tell my fellows and residents is, if they've had antibiotics in the last 90 days, those are the patients we're thinking about these, and it's IV antibiotics in the last 90 days are the ones we're thinking about these agents. So gone are sort of the, are on dialysis at baseline, et cetera. I'm not saying, again, if the patient is sick and is coming in, I'm not saying you shouldn't treat that, but these are sort of based on data that are available. So typical regimens when patients are coming in. So if you're not thinking Pseudomonas, so community-acquired pneumonia, coming in septic and sick, sort of the standard antibiotics. So vancomycin for gram-positives, just in case, ceftriaxone or piptazo. You can do a lower dose piptazo that is not that does not have Pseudomonal activity. Again, a lot of these workhorses for hospitals, the piptazo versus the cefepime or ceftaz, is dependent on your formulary and what is available locally, and again, what your susceptibility patterns are for your institution. If Pseudomonas is suspected, so if they've had IV antibiotics in the last 90 days, if they've been hospitalized for at least 5 days and they have a VAP now, if they are in renal replacement therapy in the ICU and have a VAP, you want to be treating with an agent that has some Pseudomonal activity. Again, your agent of choice is going to be dependent on what your antibiogram is for your hospital. Each of your hospitals should be publishing this, and so we do this every year. Cefepime is still the most active at our institution, with ceftazidime pretty much close behind, and actually these sort of lingering behind that. So sometimes I get called for meropenem because the patient's really sick and we're worried. And that's where sometimes I say, well, if you're actually worried about Pseudomonas, then actually cefepime might be a better drug, depending on the situation. And of note, empiric antifungal therapy is not typically recommended for most patients coming in who are not neutropenic, where you're not worried about the Candida being a potential player. All right, so looking at more specifically multi-drug resistant organisms, so extended spectrum beta-lactamase producing gram-negative rods, or ESBLs as we call them. And I'll present a case just to sort of illustrate this. So 61-year-old woman has recurrent urinary tract infections or UTIs. She's got fevers, chills, flank pain. She's hypotensive, her blood cultures are drawn. She started on piperacillin tazobactam in the emergency department. This is the antibiogram, but I'm going to color code it just to make it easier for people to see. The red is resistant, the green is susceptible. So she's got some susceptibility. She has ceftriaxone resistance. She has had recurrent urinary tract infection, so she's gotten the oral agents, Cipro, Levo, trimethoprim, sulfamethoxazole previously, so she's resistant to all of those. So she basically has piptazo, cefepime, and the carbapenems available, as well as some aminoglycosides, which we sometimes use. So again, this is sort of for reference later on, but basically this is sort of just dividing these antibiotics into the classes that we sort of think of, the beta-lactams and fluoroquinolones, and how do bacteria get their resistance. There's a variety of ways for them to do it, but for ESBL, so these that are extended spectrum beta-lactamases that are chewing up the beta-lactam antibiotic, they typically will pump it out or somehow inactivate it with hydrolysis or acetylation. I can't even say that. There are many ESBL mechanisms. So I actually dislike using the term ESBL because we don't actually test for ESBL in the lab because it's highly difficult to do. So I actually like to call them ceftriaxone resistant because that's the thing that we know. And we use basically the guidance from in the United States from our governing body called the CLSI suggested using ceftriaxone as the cutoff because almost every lab will do ceftriaxone susceptibility testing. And therefore, if it's non-susceptible to that, you should assume that it may be an ESBL. It is not always, but typically that's the thing that we see. And so by doing that, the guidance has said, in these patients who have a gram-negative rod that is ceftriaxone resistant, except for what I will call AMP-C producers, which I'll talk about next, really we should not be using cefepime, which is something that we used to do, or piptazo, and that really these patients, especially if they're coming to you in our septic, really should be getting a carbapenem. And so this is pretty broad. It's broader than we would like, but it is what's recommended, and this is based on small studies showing that cefepime is not as good, and then a randomized control trial that compared piptazo to meropenem There are issues with this trial. This was the Marino trial. This is one of the only few comparison trials of old, I would say older antibiotics in infectious diseases. So these were patients who had gram-negative rod bacteremia with ceftriaxone non-susceptible, so intermediate or resistant. They were randomized to get piptazo or meropenem. And basically it shows there was a mortality difference. So patients who received meropenem were less likely to die than those that received piptazo. There were a lot of this was published in JAMA. When they went back and looked at it, there were some problems. So one of the major issues is that testing for piptazo susceptibility is actually in this study actually showed that it did not work as well. And so when you reclassified all of the gram negatives, it actually showed that many of the patients who received piptazo actually were resistant, intermediate or resistant. And therefore, when you redo the analysis, the mortality difference decreased to 5%. So that didn't meet, it was a non-inferiority trial. So technically it did not meet the non-inferiority, but there was still a trend to increased mortality in the patients who received piptazo. There was also a difference in sort of the common resistance mechanisms, so the ESBLs that were present. So CTXM is the resistance mechanism that's most present in the US. OXA48 is more common abroad. Most of the study was done abroad. There were no US centers that were involved, and basically showed that those patients had more ESBL based on depending on which resistance mechanism you had. So despite this, the IDSA, which is the Infectious Disease Society of America, still decided that a carbapenem is better. We should avoid piptazo in patients who have this, who have bloodstream infection, which would be most of the patients that you're seeing in the ICU. People say, what about cefepime? There are data showing that if you use cefepime, there's a trend to increased poor outcomes and mortality in patients who get cefepime versus a carbapenem as well. We have some data that we published, very small retrospective cohort study, but ours in the Beth Israel Deaconess Hospital, which is across town, also published a small cohort as well. And there are some data out of Hopkins from many years ago that also showed that. So based on that, the IDSA still says that a carbapenem is preferred. So this patient that we saw had initially been on piptazo, the susceptibilities returned, they were still not doing great and had been transitioned to a carbapenem. So that's a little bit about ESBLs. Once they've sort of passed their septic point where carbapenem is where a beta-lactam is less needed, switching these patients to an oral regimen is fine with a fluoroquinolone if they're susceptible, or other agents. All right, switching gears to AMP-C beta-lactamases. So these are a different type of resistance mechanism. So it's the same patient. Now they're started on cefepime. The poor ED resident realized that, they put the other person on piptazo, so let's do cefepime this time around. So this patient gets Enterobacter cloacae. So similar order here of the susceptibilities. So we have piptazo, which they did not select. This patient actually has ceftriaxone susceptibility, very good cefepime susceptibility, and the carbapenems. Again, this person has recurrent urinary tract infection, so the oral agents that we typically use for that are resistant, as we would expect to see. So it's the following day, her hypotension has resolved. She had repeat blood cultures, although you don't necessarily need to do that anymore for gram-negative rod bacteremia. And the question is, do we continue the cefepime? Do we switch her to ceftriaxone? Does she need a carbapenem, et cetera? And this patient, actually, she can stay on the cefepime. And everyone would say, well, why wouldn't you narrow to the ceftriaxone? She's doing better. It's a narrower spectrum antibiotic. And the reason for that is that Enterobacter is one of the odd bacteria out where they can harbor these AMP-C enzymes. About 30% of the Enterobacter harbor this. And basically, so it looks like it's susceptible to ceftriaxone and piptazo and cefepime. But what can happen is if you give beta-lactam, so if this patient had gotten piptazo or had gotten ceftriaxone or cefazolin, let's say, the AMP-C can get turned on and basically starts to hydrolyze the antibiotic and makes the antibiotic ineffective. So the patient may respond initially, but then AMP-C will be turned on in these bacteria and will fail therapy and typically will become bacteremic again. There's a couple different ways that AMP-C can work. Like there's this inducible resistance that can be caused, which I'll show on the next slide. There's a non-inducible chromosomal resistance that can get turned on and stay on, and then there's very rarely a plasmid mediated resistance that can transmit from one bacteria to another. And basically, so there's a little bit of AMP-C that always gets produced. In this middle one, this is a bacteria, sorry, this is a bacterial cell wall, the outer membrane and the bacterial DNA. And here's the cell wall. Here's your beta-lactam that comes and it binds to the porin, trying to kill the bacteria. And as it gets degraded and brought in, it turns on this AMP-C, and then the AMP-C chews it up once it gets inside. So it renders it ineffective. And this is where AMP-C is just turned on all the time and it chews it all up. That's sort of the too long didn't read quick version, but essentially AMP-Cs are sort of special bacteria that we need to keep in mind when we're thinking about our empiric antibiotic regimens in patients who may have had these pathogens in the past, or when they sort of pop up in their cultures. So many of us learned, this in medical school. There was SPICE M, there was M space to try to memorize these. And this actually all changed based on data. And so the new acronym is Heck Yes, which I kind of just like this picture, so I put it in there. So here are the ones that we need to think about. Hafnia, which is rarer, but it's definitely one that we can sometimes see. Enterobacter cloacae, which I would say is the most common and one of the ones that you will see in your practice. Citrobacter fruendi, and it's not all Citrobacter. There's a few types of Citrobacter, but it's really the fruendi is the AMP-C producer. Klebsiella aerogenes, which used to be Enterobacter aerogenes, so it was much easier to have in here, but they switched the name. This is what the taxonomists, I never remember what they're called. They change all the names of the bacteria. They're changing all the names of Candida, so soon to come to your lab near you. But Klebsiella aerogenes, and then Yersinia enterolytica, which Yersinia is not a super common bug that we see. So I would say the three middle ones: Enterobacter cloacae complex, Citrobacter fruendi, and Klebsiella aerogenes are the ones to sort of keep in mind. Serratia, the IDSA removed Serratia from their list, but I would say I've had a couple bacteremic Serratia patients that did not do well, and that gives me a little bit of chest pain to think about giving them ceftriaxone, but that is what they recommend. I have listed the guidance down here. This guidance is actually pretty phenomenal. It's updated every 6 to 12 months. Pranita Tama is at Hopkins. She's a pediatric ID physician there and runs their pediatric stewardship program. And it has multiple other authors, including pharmacists. But the link is here. It should still work. The Infectious Disease Society just revamped their whole website right before I put the slides together, right after I put the slides together, but that should still work. And I always just click on that to go to the latest guidance, and it has all of these updates in there. So again, so when you see one of these pathogens, if your lab is not, doesn't sort of mark them, just to remember, if it's listed as ceftriaxone, ceftazidime, or piptazo susceptible, we don't trust those, because if we give those, the AMP-C can get turned on and render those antibiotics ineffective. Cefepime is known to work. Mark Seidner was a co-fellow of mine, is on faculty here now. And he published a nice paper in 2014 looking at a retrospective look at cefepime versus a carbapenem for Enterobacter bacteremia, and patients did just as well, regardless of which antibiotic they received, and that's some of the data they used at the IDSA. And then fluoroquinolones are fine. And then, if you don't know what the bug is, or you don't have your susceptibilities back, then a carbapenem makes sense. We are lucky here at our lab. We will mark the cultures. So if it comes back and it's one of these AMP-C bugs, there'll be a little flag next to ceftriaxone that, unless it's, cystitis and the patient is better, like that, we really should be changing the antibiotic to a carbapenem or to cefepime. So something to discuss with your lab if they're not reporting that out and it's not common knowledge. This is just the similar table for AMP-C producers that, in patients with not uncomplicated cystitis. So anything other than uncomplicated cystitis, that cefepime or carbapenem would be your drug of choice, especially for somebody with sepsis. And then the other agents, should they be needed for oral therapy. All right, so that is AMP-C. So this person was stayed on cefepime and then was switched to, actually they had no oral options because she was UTI. So she stayed on cefepime for her treatment course. All right, case number 3. So maybe a little bit more what you might not see in the ICU, but see as a pulmonologist. Although a little bit less now with Trikafta, but 22-year-old with cystic fibrosis who has a fluoroquinolone allergy. She's coming in with fevers, hypotension, blood cultures are drawn. She started on cefepime, and she has a blood culture that is growing Pseudomonas aeruginosa. She's susceptible to the aminoglycosides and fluoroquinolones, but she has an allergy in which you can't give the fluoroquinolone. I will say that we try to give antibiotics, even depending on what the allergy is, but she's unable to get the fluoroquinolones. And the first line beta lactams that you would normally use for Pseudomonas are all resistant. So the question is, what do we start her on? Because usually this is the initial susceptibilities you will get, and sometimes you need to ask the lab to add on other susceptibilities. So Pseudomonas, as you all very well know, is sort of a different beast and can do all sorts of things with resistance. So it's great with efflux pumps. So it changes its efflux pumps and easily pumps out some of our antibiotics. Some of the antibiotics, it changes the porins, so it doesn't allow the antibiotic to actually get in. It can sometimes have AMP-C, and it can just have a wide variety of resistance mechanism evading all of the antibiotics that we want to use. It can be sneaky, and it can have resistance emerge while people are on therapy. Some of it can be, mixed population. Some of it is just Pseudomonas being really smart. One of the teaching points I always try to make to residents and fellows are really that, again, if I have all of my options here, I'm not going to select the carbapenem. Meropenem is not better just because it's broader and it's sort of newer when you look at some of the other agents here, because actually Pseudomonas will develop resistance much more quickly when a carbapenem is on board to that carbapenem than to cefepime or ceftaz or piptazo to the other beta lactams. So the other beta lactams are actually much better at killing Pseudomonas and have a higher barrier to resistance for it as well, which is important. And because the resistance mechanisms are so varied, you can interchangeably use your antibiotics despite what your resistance is. So if your lab tells you that the Pseudomonas is cefepime resistant but ceftazidime susceptible, it is completely fine to use that ceftazidime. Similarly, if it's piptazo susceptible but cefepime and ceftaz resistant, the piptazo should work. So it doesn't sort of have cross resistance the way that we think of with some of our other bacteria. And the thing that's exciting and I know some people may not have access to all of these antibiotics, but there are many more antibiotics now to treat Pseudomonas than there were, 10, 15 years ago. I would say de novo patient coming in and you think they have drug-resistant Pseudomonas, ceftolozane tazobactam, if you have access to it, is the drug of choice. Ceftolozane is a cephalosporin. It was designed specifically for Pseudomonas to treat resistant Pseudomonas. And it's combined with tazobactam, just like piptazo, and it can resist the AMP-C hydrolysis. And so it is a fantastic drug. There are data from the United States, there's data from our own and our own internal data at our hospital that most of our Pseudomonas, even when it's very drug resistant, ceftolozane tazobactam will be active, especially if they haven't been exposed to it. Cefiderocol, which we thought was going to be sort of the magic drug for everything, has not panned out to be as great as we would like it to be. Cefiderocol has a unique design. It has this iron moiety that allows it to sort of trick bacteria to try to get it in. The problem is all the clinical data show that it does not work as well as we would like it to be, even though the in vitro data show that it's very active against many of our isolates. So I have cefiderocol sort of as my last line regimen of something to use, just because we just haven't had as much success with it in patients with drug-resistant bacteria, including Pseudomonas. Ceftazidime, avibactam. So ceftolozane tazobactam and ceftaz-avi sort of came out at the same time. And so this is ceftazidime as you know it, as a third generation cephalosporin combined with avibactam, which is this beta lactamase inhibitor. It does have some activity against AMP-C, and so is able to sort of help with the Pseudomonas. The interesting part is exposure to ceftolozane tazobactam for Pseudomonas can render it resistant to both ceftotazo and ceftaz-avi. So there are similar mechanisms that the mechanism of resistance that Pseudomonas develops for ceftotazo can render it resistant to ceftaz-avi. We do have isolates that are ceftaz-avi resistant, ceftotazo susceptible, but there's data out of Hopkins showing if you give an extended course of ceftotazo, the likelihood that they'll have ceftaz-avi resistance increases with the longer course you give. So again, sort of thinking about, as I mentioned briefly earlier on, trying to give the shortest duration possible when you're using some of these agents. And then imipenem relebactam, which I think is the most recent one to come out, is our well-known imipenem carbapenem with relebactam, which is a beta-lactamase inhibitor, and it inhibits AMP-C. So it's a nice drug to be able to use for this. So we sometimes have activity for this as well. The drug that is missing here, for some of you who may be aware of it, would be meropenem vaborbactam. So that's meropenem linked with a beta-lactamase inhibitor called vaborbactam. The issue is for meropenem-resistant Pseudomonas, only about 1% will be susceptible to meropenem vaborbactam. So we don't even test it in our lab because the likelihood that it will be susceptible is very low. And that's just that vaborbactam doesn't help with the resistance mechanisms that Pseudomonas has. But the most important part is there's no clear magic bullet here because the susceptibilities can vary. But I would say for the most part, at least in the United States, your ceftolozane tazobactam really is sort of your first drug that you would reach for. And so these are just the added susceptibilities. So we did cefiderocol, which was susceptible, ceftaz-avi, ceftotazo, imiral. Minocycline shouldn't be here. That's a typo. Sorry about that. Minocycline doesn't have activity against Pseudomonas. So ceftolozane tazobactam is the drug that we used for this patient. Again, there's guidance at this website, as I mentioned, and the first line would be the ones that I mentioned, and putting cefiderocol as an alternative for patients. And I think I mentioned all of these other things that are listed here. What about combination therapy? This is a common question that we get. I think it's something that we were all trained on, trying to give dual therapy for Pseudomonas. It really is only recommended up front. So if you have a patient coming in, you don't have all the susceptibilities, they're highly septic, you're very concerned that they have a drug-resistant Pseudomonas, yes, I will give combination therapy up front with a beta-lactam and an aminoglycoside. But once you have susceptibilities, the data show that you don't necessarily need dual therapy. The only place where we may not do that would be a patient who has cystic fibrosis, where we typically still use dual therapy for sort of a clean out or a severe infection. And part of that really is that there are so many, for cystic fibrosis patients or patients with bronchiectasis, there are so many colonies of the Pseudomonas that are in there, and we are not capturing all of them when we do their sputum cultures, that usually we still try to do dual therapy for those patients. We don't recommend inhaled therapy as a mechanism of treatment of pseudomonal pneumonia. Obviously, it is used as a regimen for cystic fibrosis patients and bronchiectasis patients long-term for sort of suppression, prophylaxis / trying to keep them sort of out of the hospital and off their systemic antibiotics. And again, sort of, if patients have carbapenem resistance but are susceptible to the other agent, that's okay. We can still use those other agents. So this patient received ceftolozane tazobactam. It's just at 3 grams Q8, and it's given over 2 to 3 hours. Again, we are fortunate here. We have access to an excellent microbiology lab who can do testing for us, as well as excellent formulary where we actually have all of these antibiotics in-house and ready to go should we need them. But I know that that is not an option for all patients. I know that colistin and polymyxin B may still be some agents that need to be used. We fortunately have not really needed this, although I think we gave some colistin over the weekend. But those are agents that we really have been able to stop using because we have these other antibiotics. All right, switching gears. One of my favorite questions is vancomycin and piperacillin tazobactam cause renal failure. So again, one of the few randomized controlled trials that we have in infectious diseases. This was the ACORN trial. It was now published about 1.5 years ago. and was comparing cefepime. It was a beautifully done study. It's in one hospital, but patients coming in who a team was going to give either cefepime or piptazo were randomized, because you can give either drug as long as either drug was warranted. And so they monitored them prospectively. And basically what it showed is that, they were able to randomize about 2,600 patients, 1,200 got cefepime, about 1,300 got piptazo. Many of them got Vanco for the first few days as well. I think it was about 70 to 80%. And essentially there was no difference in death or kidney injury for patients who received cefepime versus piptazo. So there was no real difference between the two in terms of what happened in terms of the renal function or their or death. The one thing that did come out of this is it showed that patients who received cefepime were much more likely to have delirium or coma. And so this was actually statistically significant. But when you actually look at the numbers, it was about a third of a day difference between the two, which I guess 8 hours in the ICU, delirious or in a coma, can make a difference. But to me, clinically, it seems like we should really just be picking the antibiotic that, the patient needs. This is just an interesting graph. Cefepime is in pink. These are days of therapy per 1,000 patient days. Piptazo is in blue. This is when the ACORN trial was published and people sort of stopped using cefepime and started using more piptazo, and then it sort of split again. I actually looked at this last week because we did a journal club with the emergency department residents, and actually if you go out, it looks like they're now flipping again, where piptazo is coming up and cefepime is going down as of February. So we'll see how that looks. Should we change our management because of this delirium? I definitely get more calls that people are delirious on cefepime. I think we overcall it quite a bit. Our neuro ID person here has actually said she would love to do a study looking at actually, doing EEGs on all these patients and seeing if they are truly having, toxicity from their cefepime in that sense, as well as a full sort of evaluation for delirium. What can we learn? I would say from this trial, choose the antibiotic that makes sense. I think, again, sort of we frequently cover or treat for Pseudomonas. Do they actually have risk factors? Again, most of your patients in the ICU will have risk factors for Pseudomonas infection. And I think my big thing is, if you can get either antibiotic at your institution, does the person need enterococcal coverage? That's, do they have a biliary disease? Although people would argue whether you need to treat for enterococcus there, but do they have some GI illness, where you need potentially enterococcal coverage and where you need anaerobic therapy, then piptazo makes sense, instead of having to give them cefepime plus potentially metronidazole. But if a patient is coming in, and you're not worried about enterococcus and you don't need anaerobic coverage, I would say go narrower and go with the cefepime, ceftaz, ceftriaxone, depending what that is. All right, in about 2 minutes left, so I think we'll be fine. So a few clinical pearls. As you all know, timing of antibiotics is important in sepsis. The sooner the better. Give the beta-lactam first. So actually trying to give the beta-lactam agent before the vancomycin has been shown to help make a difference, and then give the others. We actually have this set up, at least in our emergency department, that there's instructions to infuse the beta-lactam before they give the Vanco. The Vanco infuses much more slowly as well. Most beta-lactams you can push over 5 to 30 minutes. Follow your local resistance patterns or your hospital antibiogram so you're aware of which agents you should be using empirically, because again, some of the ones that may work for our hospital might not work for yours, depending on what it is. Again, sort of assessing the assessing for resistant organisms when thinking about the patients coming in. Remember your heck yes, that you shouldn't be using, ceftriaxone or piptazo, really cefepime or carbapenem for these because of the AMP-C. Carbapenems for your ESBL producing or ceftriaxone resistant gram-negative infections. And if you're able to get extended testing on your drug resistant Pseudomonas, you should do that. And that ceftolozane tazobactam in the United States upfront should be your drug of choice, again, if you're able to have it at your institution. And I will stop there. Thank you so much, and looking forward to the question and answer session a little later.